Good afternoon all. Today I'm going to present our work on third nerve palsy, medial rectus resection versus fixation to the medial palpebral ligament. So we know that surgical management of oculomotor nerve palsy is very challenging. It requires meticulous surgical planning. There is no clear consensus about treatment, and it usually results in long-term surgical undercorrection. So our aim was to compare the results of lateral rectus deactivation combined with medial rectus resection and combined lateral rectus deactivation with medial rectus fixation to the medial palpebral ligament performed in the same operative session for oculomotor nerve palsy in terms of successful alignment and ocular morbidity. It was a retrospective analytical study between Jan 2006 to June 2020 at Arvind Eye Hospital, Madurai. We had a total of 35 patients. So all our patients with complete oculomotor nerve palsy with large angle exotropia, more than 50 prism diopters, underwent lateral rectus deactivation of the affected eye. In group 1, we combined this with medial rectus resection, and in group 2, we combined it with MR fixation to the MPL. Our inclusion criteria were all patients with oculomotor nerve palsy with a follow-up of at least 6 months after diagnosis. We excluded patients who underwent previous strabismus surgery or those with neurological abnormalities. So all our patients underwent a detailed ophthal evaluation, including oculomotility testing and measurement of the deviation. The FDT, FGT in clinic was done for all adult patients. Intraoperative FDT was done for all patients. All our patients were operated under general anesthesia by a single surgeon. We measured the ocular deviation on postoperative day 1 and 6 months. Our success criteria was a horizontal deviation less than or equal to 20 prism diopters in primary position at 6 months post-op. So for lateral rectus deactivation, after isolating the LR, it was hooked with secured with a 5-0 polyester suture, disinserted from the globe. We then made a hockey stick incision over the lateral orbital rim, exposed the periosteum and posterior tenons, retrieved the LR and secured it to the periosteum and closed the posterior tenons. In the first group, this was combined with 10 mm of MR resection. In the second group, we fixed the MR to the MPL. So after exposing the MR and the MPL insertion, we passed 5-0 non-absorbable sutures through the insertion of the MPL, including the periosteum, and then tied these two knots together. We then passed an empty semicircular needle through the skin, through the conjunctiva, above the MR insertion. We threaded this needle through the semicircular needle so that we brought it out above and below the insertion of the MR. We then secured this to the MR insertion superiorly and inferiorly and fixed the eye in 10 degrees of ISO. So we had 20 patients in our resection group, 15 in fixation group with an age range of 3 to 65 years. We see that on post-op day 1, both groups performed excellently, correcting the exotropia. But at 6 months post-operative, only 65% of patients in group 1, as compared to 93% of patients in group 2, could maintain this. If we see, the results are not statistically significant. What is statistically significant is the residual exotropia at 6 months post-op between the two groups, with group 2 performing much better than group 1. So we did not observe any significant postoperative complications in the resection group, but the fixation group had persistent medial conjunctival congestion in one patient with a suture granuloma in the second patient. So this is a preoperative and 6 months postoperative picture of LR deactivation with MR resection. And this is LR deactivation with MR fixation to the MPL, 6 months post-op. So in the first group, we felt it was a technically simple procedure, no important structures present laterally. The post-exotropic drift could be due to slackening of the MR, and there was less severe limitation of ocular motility. In the second group, being with a fixation to the MPL, it was slightly difficult with extensive tissue dissection, poor cosmesis. You can have injury to lacrimal sac and angular vessels, persistent epiphora, and severe limitation of ocular motility post-op. Our limitations are that RCTs would be better to assess the procedure. We did not see them beyond 6 months. The number of patients in each group are different, and due to our relatively small sample size, our results were not statistically significant. So in conclusion, we would like to say that both techniques give a good reconstructive correction of large angle exotropia, but LR deactivation with MPL fixation, though requiring more time, prevents a long-term postoperative exotropic drift. Thank you.
Thank you, ma'am.